So I'm Dr. Rankin. I'm one of the medical directors for the emergency department. I'm under Dr. McCaslin, his minion. And a lot of you may not recognize me because I'm not wearing my normal work pajamas and I don't have a complete look of defeat. That'll be about a half hour from now because I work at 11. I'm going to talk to you about encoding to the emergency department for the EMS guys. And for the nurses, it's good to know how to take an encode, also to know what else you might need to prompt the paramedics to ask for, because sometimes they're driving, they're in a hurry, they're anxious, the patient looks like they're doing poorly, and they're rushing. They may not give all the information. They may know stuff that they forgot to tell you, and you prompt them, and all of a sudden you get even more information, which can be really, really useful, especially since we do things like stroke stops. We stop people in the hallway quickly and assess them if we think they really are a viable TPA candidate. 82-year-old woman is found down on the floor. Family had called because they tried to get a hold of her, and she didn't answer the phone. So she lives alone. She uses a cane. And family had talked to her the night before, is what they reported when they phoned 911. She's nonverbal. She's awake. She doesn't follow any commands. She's fully dressed, and her bed is made. There we go. No signs of trauma or injury are noted. She has right face and arm is flaccid. What do? Well, so the paramedics get there. They evaluate, they assess, they call into the emergency department. This is the encode we got. So we got the vitals, exam details, heart rate, 92, blood pressure's high but not crazy, oxygen saturations are good, blood sugar's good. And the report was that the patient was unresponsive. She has right-sided weakness. They kind of went under the assumption that it happened last night because her bed was made and she was dressed. This was about 10 o'clock, 11 o'clock in the morning that we got this encode. No family is available to talk to, unfortunately. Medications at this point are unknown. They didn't readily see them on the scene. Obviously, if you can grab them, pick them up by all means. I know most of you guys tend to do that. And the report was that they can't get a race score because the patient is unresponsive. So then what happens? So she gets to the emergency department. She's awake and alert. She's looking around the room at you. She's nonverbal and she can't follow any commands. But she does look at you when you speak, or at least she tries to. Her gaze and head are deviated to the left side. She's got tone, and she responds to pain on the left side of her body. The right side, she really doesn't do anything. You know, pinch a toe, stick them with a broken tongue depressor. Just don't draw blood, please. Don't be that aggressive. She does have a right-sided facial droop. Even you can notice it even when she's not trying to move her face. She's clean and she's dressed. No signs of trauma. She doesn't have any obvious pressure sores. Now, this is something you may not notice in the field because typically you're not going to, don't waste your time trying to undress a patient. We'll take care of that. Our assessment is she had a stroke score that was at least a 26. There's some things that are hard to assess because she can't comply with everything that you want. I'd come up with this as a race score of 8. Now, the trick is we don't really know when things happened. Family wasn't there yet. We couldn't really talk to them and find out exactly what time they talked to the patient last. We do a rapid head CT on this lady, and it's normal. If you remember from what Dr. Franco was saying, frequently you'll start to see problems within just a few hours on a CT. So a normal CT tells me that this is pretty fresh, given the degree of deficits that this lady had, because a stroke score of 26, the bomb went off. I mean, this is a completely life-altering or life-ending stroke. We added a head CT of the head and neck, and wound up calling over to the med center, which is our protocol for the severe strokes that have the potential for things. Now, this was tricky. We didn't make her a stroke alert because we didn't know the time of onset, but I decided, this is actually my patient, I decided I was going to call over there anyway because the normal head CT tells me this is probably pretty fresh. Obviously, you don't get the head CT in the field, so you wouldn't think of that. They did bring her code 3, which was great, lights and sirens, got her to the emergency department as fast as possible. They didn't want us to give TPA because we didn't know exactly when symptoms started. So, things that you want to encode to the ER, last known well time, huge. Vital signs, blood sugar, always blood sugar. Key physical exam findings, and this is going to be your neuro exam, wake alert. Significant past medical history. if you can get it. Key medications, again, grab them. Don't trust med lists. Just get the pill bottles. So we'll see, we can pick through them too. You guys can pick through them if you have an extended drive time, especially if you're coming from one of the more rural sites. Race score, if your protocols indicate doing the race score. I know the Omaha Fire guys, that is their protocol. So last known well time, and I know that this has been talked about in every one of these talks, but the thing is we talk about it a lot because it is so important. So time of onset is a tricky way of looking at things because frequently we don't really know. Oftentimes it's when the nurse walked into the room and saw that the patient was acting abnormally, or when family found them like this. Well, I was out mowing lawn and I came in and she wasn't able to talk. Okay. Did they wake up like this? Did you find them like this? Because that isn't the time. People think of that as the time of onset. In particular, that's what you're going to get from the people, the family, the bystanders, the normal citizens. They don't think about things the same way we do, and so it's important to try and tease that out of them. Don't belabor it. If family's there, get them to the ER and tell family, just go to the ER. You don't need to gather everything. Grab their meds, go right to the hospital. Tell them what hospital you're going to as well. If they get to us and we've diverted, we'll tell them where they need to go after that, because we'll tell them, yeah, if they were coming in on the squad, we told them to go down to the Nebraska Med Center. Last known well time is a much better way of looking at things. Who saw them last at their baseline? If they have some stroke deficits previously, if you can figure out what those are, that's helpful. Sometimes the patient really may still be able to tell you. When was the last known time they were seen well? Was it when they got meds at the nursing home? Was it at breakfast? Other questions you can ask. What was on TV? What were you doing at the time? That may give clues as to the timing of it. Some people really, really live on a rigid schedule. I mean, if it's a show that's really only on once a week, we can get it at least within a half hour. If they were watching Chopped on the Food Network, I mean, good Lord, it could be any time of day. What time did they go to bed? If they woke up with a stroke, the stroke started any time when they went to bed. So did they wake up like this? And what time did they go to bed if they did? So vital signs, heart rate. Okay, yeah, that's good. If you notice it's irregular, that's actually kind of an important thing to relate to us. Tells us if they have a history of AFib. Blood pressure, and I don't know if any of your guys' protocols have any blood pressure management. It's not typically something we see in the field, and honestly, just get to the hospital. I wouldn't really mess around too much with blood pressure management. Try not to get the patient excited, because that's not going to help the blood pressure. But otherwise, you're not going to do that much in the field. We'll start managing that when they get to the hospital. Temperature, if you're set up for it, can be useful. If they've got a fever of 104, my differential's changing, and I might be thinking a lot less about a stroke. Oxygen saturation. If they're 82%, bring it up. Things might actually improve just with that. Blood sugar, I think of this as a vital sign. I love hearing a blood sugar, and the nurses that work with me will say, I always ask, what was the blood sugar? What was the blood sugar? And if they don't know, then get a blood sugar, because it's important. EKG, if you're set up for it. If not, tell us what the monitor says. Monitor shows they're an AFib. Monitor shows they're a normal sinus rhythm. Pain scale number. I'd rather know what their favorite color is, or if they're a Detroit Red Wings fan, because if they're a Detroit Red Wings fan, I'm transferring them. Physical exam findings. So its level of consciousness is huge. In that example we got, the patient's unresponsive. No, unresponsive is unconscious. They were awake and alert, they just weren't following commands. But it was actually nice the way they described it, because they went into more detail, which let us know they're indeed not unresponsive. The neuro exam, Cincinnati stroke score shows evidence that stroke is a likely problem here. The RACE score is just really useful in letting us know how severe it is, because patients can do a lot better with thrombectomies sometimes. And that's not always a clear-cut differentiation for me as an ER doctor either. I leave that up to the people who do mechanical thrombectomies to try and determine that. Sometimes they'll say, no, just do TPA, keep them there. Signs of trauma, big laceration, tongue laceration. If they have a big deformed limb, I might be a lot less inclined to give them a bunch of blood thinners, especially extremely potent ones. Did they lose control of their bowel or their bladder? Again, this is important for multiple reasons. Seizure, that happens. In the case of that lady that we talked about earlier, her clothes were dry, her clothes were clean. Anybody who's worked in the field and anyone who's worked in the ER, you guys all know, someone who laid on the floor all night long is usually, especially an older patient, is usually going to have the smell of urine or their pants are going to be full of stool. It's just common. We see it all the time. That's why most people are getting up in the middle of the night. Yeah?
So in the field, does that tell you they were probably awake most of the night?
So the thing with this lady is obviously we can't know. Her symptoms had probably just started. I kind of think it was a misinterpretation. They thought that she had actually not made it to bed. I think she had probably gotten up, made her bed, gotten dressed, then had the stroke because she was clean. She had no signs of, pressure ulcers developing, the bruising. She had her pants were dry, clean. So she probably this had just recently happened, especially with that normal CT, which is why we decided to call the med center so quick. Past medical history, meds, prior strokes, how recent, if you can get it, also what kind is useful. Because brain tumors, brain aneurysms, prior intracranial hemorrhages, that's all key information for us as to whether or not someone can or cannot get TPA. Recent surgeries can matter, blood thinners. And personally, I find sometimes people may say no to, kind of like when you ask them, hey, do you have any medical problems? No, I don't have any medical problems. Do you take medicines on a daily basis? Well, yeah. What do you take? Well, I take this for my blood pressure, and I take this for my cholesterol. Sometimes say the names. Are you on Coumadin or warfarin? Eliquis, Xarelto, Pradaxa. Oh, yeah, I take that. Okay, good. When did you last take it? Because they don't always know why they're taking medicines. So sometimes spitting out key names can actually be useful. And that's something you can do during your transport. That can be information you gather kind of while you're starting to get ready to do your encode. I kind of agree. A swoop and scoop sometimes is the way to go. Don't spend a lot of time on scene. You're going to be much better off getting them to the hospital. We can waste our time there. The RACE score, yeah, we've talked about it, how to do it. So again, it's aphasia with right-sided weakness. One thing about asking people to do these commands, he said, if they have right-sided weakness, ask them to do the left hand. That's because that's the one they're really going to be able to move well. With aphasia, the one trick is that the patient may actually be able to read visual cues, and they may mimic you. If you can, the first 1 or 2 times you ask them to do something, don't show them. Make a fist with your left hand. Just say it. Because they may not do anything, and they'll look at you with a look like, you got 2 heads. Because they're hearing garbled nonsense. But if you do this, they may bring up a fist or close their eyes real tight because they see you doing it. It's a visual cue. Oh, they probably want me to do that, so I'll do it. 5 or more, the studies would indicate that may warrant transfer to a comprehensive medical center or someplace that's thrombectomy capable. In the setting where you are way out, get to the closest hospital. We can try and start sorting stuff out there. Case 2, 82-year-old male. Acute onset of left arm weakness while eating breakfast at 8 a.m. He was with his wife when this one started, and she actually saw it happen. Dropped the fork, couldn't pick it back up. Got to the ER within 40 minutes. People never call 911 right away, let's be honest. The stroke score, by our assessment that we do, the NIHSS stroke scale, there was a 9, which is a pretty decent stroke. Facial weakness, left arm, left leg were both weak, ataxia in the limbs, and then sensory loss. Patient got TPA in the emergency department, had rapid improvement. Like Dr. Franco was saying, frequently when they improve instantly, there's a darn good chance that was going to happen anyway, but we don't know. You can't assume, well, this is just going to be a TIA, because you'll only know if it's going to get better when it decides to get better. And if it doesn't, and you wait for it to happen, you've probably missed the window. Another thing about TIAs, with regard to the time of onset, if they're having these starting and stopping lesions, like they have a recurrent TIA a couple times in the last 24 hours, technically, each new event is considered a new event. When did this episode of numbness and weakness start? Not when did they start having episodes? That might be useful to know. But if this episode started 15 minutes ago, we're working at 15 minutes. So that's another useful thing to know, another nice little bit of information to gather, because each event is an individual event. So reasons to give thrombolytics. It's actually a really, really small list of indications. 18 years or older, last known well time, less than 3 hours, 4.5 hours with some additional criteria. You notice it doesn't say stroke, because we don't know. We will give this medicine. We may think it's a stroke. We don't know. With regard to it being a seizure, with regard to it being a migraine or conversion syndrome, it may be. I will have no means of proving or disproving that most of the time. And so, as he said, as Dr. Franco said, not a lot of these patients bleed. So it doesn't say stroke because, again, we can't prove it when we give this medicine. I tell patients that all the time. Now, the list of contraindications, on the other hand, is voluminous. Platelet counts matter. And a lot of this stuff is stuff you're not obviously going to get in the field. Coumadin use with an elevated INR, Xarelto or Eliquis, 48 hours. Pradaxa, 72 hours. Honestly, if they tell you they're taking Erixtra or Gatroban, that doesn't happen, except in the rarest of occasions. Heparin within 48 hours means they probably had a procedure. Lovenox within 24 hours, maybe it's a pregnancy-related problem. They have a history of hypercoagulable state. Serious trauma in the last 2 weeks. Intracranial surgery in the last 3 months. That one would make me nervous. I'd be like, God, they just had brain surgery, and you want me to give them something that's going to take away all clotting in their brain. Any history of brain tumor, aneurysm, intracranial hemorrhage, or an atriovenous malformation, they're out. Recent bleeding, serious head injury, and some of these get kind of vague. Serious trauma, serious head injury. Leave that one up to us. But if you find out about it, please relay it to us. CT after onset demonstrating hemorrhage or subarachnoid hemorrhage symptoms being present. If you're doing a CT before onset, then you really need to curb your testing. And then after treatment of blood pressure, if they're still over 185 systolic or 110 diastolic, there's more. Pregnant. These are relative contraindications. Call the OB and talk to them. Major surgery in the last 2 weeks. Call a surgeon. A recent LP, post-MI pericarditis, which honestly, we never see that. MI or ischemic stroke in the last 3 months, you're going to end up talking to a cardiologist or a neurologist about it. If it's over 3 hours and they have a score of 25, or they have an INR 1.7, they're out. We can't give them TPA. Now, there's also the mechanical thrombectomies. That's done at a comprehensive stroke center or a thrombectomy capable center. So it's the Med Center, or Emmanuel actually is thrombectomy capable. Technically, it's still listed as being up to 16 hours from last known well time, including wake-up strokes. 24 hours in certain patient populations. Stroke score over 6, which isn't super hard to get, but it isn't super common. Over 80, and significant disability at baseline. Those are, lots of times dementia would be included in that. Those are the reasons that they're not going to be taking a patient for a thrombectomy. They'll grill us on that when we call the Med Center if we're doing a transfer. So the key takeaway points in this is, again, it's last known well time, so important. Again, if it's a stuttering on and off kind of thing, it's the time this most recent one started. But it's all about when was the last time anybody saw them normal. Keep asking the question, too, for the nurses, for the paramedics. If the story keeps changing and you get this really wide range of times, you can tell us there's a wide range of times. I like to know the one that is first, the earliest one, because I don't want to give the medicine outside of a window because the risk of bleeding is going to go up significantly. For certain patients, thrombectomy might be better than TPA. Uncooperative and unresponsive are two entirely different things. When doing that race score, one thing, with this patient that we had that I noticed is if I picked up her right arm, it would just slap back down on the bed There was no assist. Frequently, though, I bet most of you guys, if you think about it, would know when you have a patient, when you lift a patient's arm, frequently they help you a little bit. It's not dead weight. And then when you let go of it, they bring it back down to their side. It doesn't just slam down on the bed. They may not be able to cooperate, but it can at least tell you, this right side is dead. The left side, they seem to do stuff. If you pinch it and they pull it away, or you pinch it and nothing happens, that could be telling, especially if they're not really able to follow the commands, which is ideal. But in a patient that's aphasic, they really may not be able to do what you want them to do because they just don't understand you. Time is brain. It's not as catchy as time is muscle or time is money, but time is brain. Transfers take time, kind of like Dr. Schmidt was talking about. And there's nothing you guys can do about that. There's nothing we can do about that. If they have a high race score and you can relatively reasonably get to a comprehensive stroke center and your protocols allow it, because not everyone has protocols written like that, you got to follow your protocols. I could make an argument that may not be a bad idea. When in doubt, just get them somewhere, though, is definitely always going to be the best bet, and we can try and sort that out. But the sooner you can get them to us, the sooner we can start working on transferring them if that's appropriate for them. And sometimes, Dr. Schmidt said, sometimes transfers can take a long time. Look for the blood thinners, always huge. They've got a history of AFib. There's a good chance that they're on one. If their pulse is irregular, there's a good chance they're already on one, unless it's a new diagnosis that we don't know about. And grab their meds if you can. Any questions? Yeah.
If a patient is taken to Women's Hospital and it's determined that they're a TPA candidate, can you guys get them? Do they initiate the TPA there before you transport them?
Yeah, we do. And frequently we will, even before we start looking at a transfer. Obviously, I'm not keeping anyone who's getting TPA at the Women's Hospital because the gynecologists will not know what to do. They don't want to know about that. They just want to get the pelvic exam done before the TPA is given. We're going to be transferring them. And we will start the TPA before transfer. We'll talk to whoever, if we're transferring them to Methodist Main Hospital, which is where the vast majority of them do get transferred to. And we'll admit them there. We'll run the TPA course and have neurology evaluate them if they're going to the med center. Frequently, they'll still want us to give the TPA, and then we will send them there. We'll start calling for our transport as soon as we possibly can, as soon as we really know that patient is going to go, especially if they're a TPA player, because we want to get them transferred as soon as possible. I always get a little antsy when I'm talking about putting someone in whom I've given this super blood thinner and a bouncy car down Omaha roads. So, yeah.
If I'm coming from a rural call,
Mm-hmm.
and I'm going 5 stroke patients, they're 8 or 9 on our scale, so they're a critical stroke patient. And I'm going past 200 before the Dodge, thinking of the med center, or I'm at least anticipating that. Do I stop at your facility and get TPA or a BLS? Stop at your facility and get TPA, or do I keep going with this?
I guess that could kind of depend, potentially. If you're really close to us and it's not going to be an extended transfer time, encode to us. Because we may say, you know what, you're better off going to the med center. We may say stop. Believe it or not, we actually try not to divert everything. I know some of the rural medics might say that's nonsense, but we do. I try to not divert everything. I'm not looking at you. I'm looking at you because you asked me the question. But the trick is sometimes it may be more appropriate. Now, then you're also going to get into, is it 2 in the morning? Because let's be honest, the way I drive, I could get down to the med center in about 10 minutes. And that's without lights and sirens. If it's 7:30 in the morning, no, you're not getting anywhere, man. You're probably actually better off stopping at Women's Hospital because we can evaluate, we can do the CT imaging, we can start the thrombolytics, and start making arrangements for transfer. So that could be situational, and I'd say, again, when in doubt, if you're not really sure, first of all, encode and give us the data. Second of all, if you're not really sure, bring them to us, and we can try and sort it out from there, because it isn't always clear. It may end up being a hemorrhage, and then we'll want to get them started on the blood pressure meds as soon as possible. Start reversing any anticoagulation they do have. Again, you can't tell just by looking at them if it's a hemorrhage or if it's an ischemic stroke. Personally, I hate the term stroke because it's so vague. It's like saying they had a heart event. Doesn't mean anything other than something happened with their heart. So when in doubt, just get to the closest hospital. We can start sorting it out from there. Yeah. Any other questions? Nicole? All right.
All right. So we are pretty close on time. Thank you.